Hello, my name is Dr. Kimberly Cheatham, and welcome to this presentation on abnormal labor. The objectives for this presentation are listed here. The obstetric term dystocia is defined as abnormal labor. Dystocia can lead to an abnormally slow labor, which is called a protraction disorder, or it can lead to no progress in labor at all, called arrest of labor. Dystocia results from an abnormality of one of the 3 P's of labor mechanics: the powers, the passenger, or the passage. Let's look at each of these 3 categories and how abnormalities in any one of them can lead to dystocia. An abnormality in the powers of labor refers to insufficient contraction strength to cause the necessary cervical change required for delivery. A differential diagnosis for inadequate powers is suggested here. How can we tell how strong contractions really are? The monitoring of contractions in labor can be accomplished several ways. One way is by palpation, but this necessitates the constant presence of a provider. More commonly, mechanical monitors are used, which can be placed externally or internally. External monitors use a transducer strapped to the maternal abdomen that detects a change in uterine shape during a contraction. External monitors can determine the frequency and duration of contractions, but not their strength. Another way to monitor uterine contractions is with an internal monitor called an intrauterine pressure catheter, or IUPC. This monitor requires ruptured membranes before placement. The catheter is threaded up through the cervix next to the baby and is filled with saline. Pressure from contractions causes the saline to move, which allows measurement of contraction strength, frequency, and duration. External monitoring is the preferred method for recording contractions because it is not invasive like the IUPC. The clinician assumes that contractions are sufficiently strong when they are painful, occur every 2 to 3 minutes, and lead to cervical change. If the cervix stops changing during labor, the most common reason is insufficient contraction strength. An IUPC can be placed to provide quantitative information about the strength of the contractions. This information guides the clinician's decision for starting oxytocin, an intravenous medication that strengthens contractions and speeds up labor. The illustration on this slide demonstrates the clinician's hand guiding an IUPC up into the uterus next to the baby. The management of dystocia caused by problems with the powers includes actions that improve contraction strength. A very effective remedy is the administration of intravenous oxytocin. Oxytocin is a synthetic medication similar to the same peptide hormone produced by the posterior pituitary that also causes contractions. If the bag of water is still intact, rupturing it with a plastic hook can help contractions become stronger. If the patient is in a lot of pain, which can also slow down labor, analgesia can be provided. Lastly, if the patient's cervix is less than 4 centimeters dilated, the slowed labor may indicate that the patient is still in latent phase, which is a time of expected slow cervical change. If dystocia occurs in the presence of adequately strong contractions, the next consideration is the passenger, or the fetus. Several possible abnormalities could be present and are listed here. Fetuses that are estimated to weigh more than 4,000 grams, or almost 9 pounds, are more likely to cause dystocia because of their size. If the fetus is lying in the wrong direction, this can also cause dystocia. Even if the fetus has a correct vertical lie, an abnormal presentation is another problem that can occur. Remember that the presentation refers to the part of the fetus that is lowest in the pelvis. The wrong part of the fetus may be presenting, such as the breech or a shoulder. If the head is presenting, it may be oriented abnormally. Examples include a face presentation or an occiput posterior position. The fetal head may also be at an uneven angle, a condition called asynclitism. Fetal anomalies, such as an enlarged head from hydrocephalus, may be present that could also obstruct the birth canal and lead to dystocia. Most of the clinical scenarios with dystocia caused by the passenger will require a cesarean section. The third category to consider as a cause of dystocia is the passage or maternal pelvis. A differential is listed here. It is recommended practice for clinicians to palpate a pregnant woman's pelvis in an effort to determine if the size is adequate for a vaginal delivery. This palpation is referred to as clinical pelvimetry. However, clinical pelvimetry has poor predictive value for successful vaginal birth. Soft tissues in and around the pelvis can also hinder progression of labor and can arise from the conditions listed on this slide. Abnormalities in the passage often require cesarean section. The risks of dystocia largely come from the associated prolongation of labor. Maternal and fetal risks from a prolonged labor are listed here. If patients are unable to proceed with labor due to dystocia, the fetus is delivered via a cesarean section. Cesareans have become very common in the last 20 years, although no improvement in neonatal outcomes has been seen with the increased C-section rate. C-sections present a higher risk to the mom and lead to a longer recovery compared to a vaginal delivery. Common indications for a cesarean section are listed here. This is the end of this presentation on abnormal labor.